Hi, and welcome to Something to Talk About. I'm Linda McNamee, and for the next hour we are going to be talking about pulmonary fibrosis, although I will find out why it's idiopathic pulmonary fibrosis. Say that 5 times fast. But before we begin, I would like to thank the crew, Corey McNeil and Mike Duvall, for helping me out and making the show look good, and also keep BCAT running, and they give a whole new definition to the term multicasting or multitasking, both. I would also like to thank, we have a little change up in crew tonight because my normal crew is having a lovely vacation this wonderful week. We have Melissa Sahagian. Thank you, Melissa. Melissa was here last show, and she's in the director's chair tonight, so thank you, Melissa, for coming back and stepping up, filling those big shoes. And I also would like to acknowledge Tembi Kiley. Tembi, I hope I pronounced your name right. And I really appreciate her too, because she just walked in, second day volunteering for BCAT, and we already have her on a live show. So thank you very much. And lastly, I would like to thank my husband Paul for staying home for Daddy Date Night tonight with Gwyneth and Evan, and hopefully you guys aren't watching too many Batman videos. If you have a question this evening, you are more than welcome to call at 781-270-9199. That is tonight, Wednesday the 23rd, live call-in. If you have a question, comment, we'd love to hear from you. If you have a suggestion for a future topic or think of your question a little too late and aren't able to write down the right email address, you can always email me at talk@bcattv.org. I love to get email. And now I would like to introduce my wonderful guests, now that we have all that bureaucratic stuff taken care of. We have Ashley Tighe DiLella.
You got it.
Okay, wow. Who works for Battle for Breath, which is a local foundation that covers pulmonary fibrosis.
Yep, so we can get into it a little more later.
Hold that thought.
Yes.
I'm the queen of tangents, which is why I have my notes here. And we also have Dr. Andrew Tager, who is one of the lead researchers, I guess you could say.
Thank you.
At Mass General Research Lab. And you focus, one of your foci is research on pulmonary fibrosis, cause and cure, I guess it's safe to say. Well, we'll find out more about that too. So before we begin, or actually as we begin, if you guys can tell me a little bit about your backgrounds, where you grew up, particularly you, where you went to school, credibility, got to build that credibility, and how you became involved in idiopathic pulmonary fibrosis. Oh, I'm just going to call it whatever.
Sure.
We'll let you take it over. So
Excellent.
Go for it.
Sure. So I grew up in North Andover, Mass. I went to school at Holy Cross for my undergrad.
Oh, excellent.
Yes. I've been in commercial real estate for about 5 years, and I'm actually currently in the MBA program at Babson College in Wellesley. Yes. And I've been involved in idiopathic pulmonary fibrosis since 2010.
Okay.
And that was kind of my first experience with the disease. My grandfather was diagnosed after a somewhat brief illness. He was experiencing the typical symptoms of pulmonary fibrosis with the dry cough and a shortness of breath. And it got progressively worse to the point where in October of 2010, he was admitted to the hospital. He was diagnosed with idiopathic pulmonary fibrosis.
IPF.
IPF, yes.
IPF.
Yep, that's easier. Let's stick with that. So he was diagnosed with IPF, and at the time, no one in my family had really heard about the disease. So we weren't really sure what to expect, didn't know what we were getting into. It was new to us. And as we quickly learned, there isn't a lot that's known about it in general, which we found challenging and frustrating. As I mentioned, he was diagnosed in October. He was sent home with oxygen. We weren't really sure what, how long we would have with him.
How old was he at the time?
He was 74 at the time.
Okay, so that's still relatively young.
Yes, it was.
Okay.
Yep. So we were all shocked.
Yeah.
And he was sent home for about 2.5 months. He was admitted to the hospital again on December 15th and ultimately passed on the 21st.
Ooh.
So yeah, it was about 2.5 months from diagnosis until the time he passed, which was very quick.
Okay, later on I'm going to want to know if that's like the normal span.
Right.
Okay.
Yeah,
So now you're working with the foundation to
So what we did was, you know, based on our experience and just the general lack of knowledge that we found, and I guess ultimately everyone's working for, especially Dr. Tighe and his team, to learn more about the disease and more for a cure. But still, there's just not a lot known about the disease. So we were frustrated by that, and you know, we wanted to do something about it. So we reached out to the Pulmonary Fibrosis Foundation, and we actually, Battle for Breath, which is what you were just referring to earlier, what we wanted to do was really help with the research, and what we did was we picked a name to kind of as an umbrella and a brand for the efforts that we would do going forward. So when we can get into it later, we have an annual walk and a Zumba
which
event.
we will definitely talk about at the end of the show.
Yes.
But first we want to encourage people to learn why we have this walk, and then by the end they'll go, sign me up, sign me up, sign
I hope
me up.
so.
Okay. Excellent.
Right.
Dr. Tighe, what's the scoop?
So I was born out in Michigan and then grew up in northern New Jersey. And I moved to New England as an undergraduate at Brown down in Providence. And then came to Boston for medical school at Harvard Medical School. And then stayed on at the Massachusetts General Hospital for my training, first in internal medicine, and then in pulmonary and critical care medicine. And it was as a trainee learning about pulmonary medicine that I first began to take care of patients with IPF. And as you know, Ashley said, their cases can often be very compelling in the sense that they get this diagnosis, there's really not much we can do for them, or historically in terms of drug therapy. It's unfortunately often a rapidly fatal disease. So
I don't know, sometimes it's, I don't know because I haven't been through it, but sometimes it's better if it is rapid than stretching out over.
So it's and we can talk about the course of the disease. It can be quite variable. Overall, the prognosis is quite poor in the sense that the average length of time that patients typically live from diagnosis, from the time of diagnosis, is about 3 years. So Ashley's grandfather was on the short end of things. We see that's not that atypical, though. We see patients that unfortunately very rapidly progress to death. Other patients can do better and can have smoldering disease that can stay stable for quite some time. It's one of the things that we don't understand about the disease, why some patients, like Ashley's grandfather, progress so quickly and others can live with this disease for quite some time. But on average, the survival tends to be on the order of about 3 years from the time the person first comes to the doctor saying, I'm short of breath, till they...
Now, does it normally affect an older age spectrum, like
so
more senior people?
Exactly. So the average patient tends to be in their 60s, but the occurrence of the disease increases with age. So we do see it in some younger people, rarely, and then the incidence just increases as people get older, to where patients or people in their 70s and 80s overall have a higher rate than patients in their 60s, but there's competing mortality, so people are getting other things, heart disease and so forth, so it's not the majority of patients. The average patient, though, I think the figure is 66 years old would be average age of diagnosis.
Now, what exactly, if you can say what exactly, is idiopathic pulmonary fibrosis?
So,
is it like a cancer, or is it like an asthma thing, or?
It is.
You mentioned
so
coughing,
fibrosis is basically abnormal scarring of any organ, and that can affect. There can be fibrosis of the liver, fibrosis of the kidney, fibrosis of the lung, or pulmonary is the word for lung fibrosis. And then lung fibrosis can be caused by many different things.
It's like an
actually.
asbestos thing from
Yeah, that's
that,
exactly. So asbestos exposure, many of people exposed to asbestos will develop lung fibrosis that we can't really distinguish from IPF or idiopathic pulmonary fibrosis, except if they have a biopsy, we can see evidence of asbestos in their lungs. But otherwise, the lung behaves very similar to how it behaves in idiopathic pulmonary fibrosis. The word idiopathic is just a Latin term for caused by itself, or meaning that we don't know what it's caused by. Now, that isn't and that's just, I think, our inability to figure that out as yet. So we think that by and large, this is a disease that requires a combination of two things. There are factors of the person involved, we call those host factors. And then there are also environmental exposures. And the host factors are typically genetic.
So there is like is it genetic or hereditary?
Well,
because I'm thinking there's a difference.
Yes, that's a very interesting question. So there are cases that we refer to as familial pulmonary fibrosis or familial interstitial pneumonitis is the technical term. And Ashley and I were talking before, that's technically defined as two people in a family, two first-degree relatives with the disease. That occurs in a substantial fraction of patients. It's not the most common. Most patients, or the majority of patients, won't have family members that are affected.
Now, in Ashley's case, was there another family member?
There wasn't, no.
That's not to say, well, not to be,
no, sure, it's
doom
definitely
and gloom, but it still
absolutely.
Potentially
and that's
could be.
Obviously one of the first questions that comes up when you're diagnosed with a disease like this is, what is everyone else's chances of contracting something similar? Because obviously it's a very traumatic and devastating disease.
And I'm wondering if, like, the risk factors or... Okay, I interrupted you.
So, no, this is great. So
I'm not even looking at my cheat sheet yet.
It's hard to estimate. I think there's the statistics and numbers around idiopathic pulmonary fibrosis are as good as we can make them so far, but we think in general it's probably underdiagnosed and underreported, so that we don't have a great, precise handle on how many patients are involved per year and so forth. But although it was initially thought of as a fairly rare disease, I think the best estimates are that about 40,000 Americans die from this every year, which is roughly the same number of people who die from breast cancer.
Really?
So it's, it really causes appreciable mortality and suffering. I mean, it's, as people get worse, it gets harder and harder to breathe. They often have a very persistent chronic cough that keeps them up at night. But mostly it's the shortness of breath that really can be a dreadful feeling. And so it's both the suffering and the death that it causes that I think makes it such a difficult diagnosis to get. But on the hereditary side, again, it's hard to also estimate what fraction of patients we would call having hereditary or familial form of the disease. Some estimates are as high as 10 to 15% of people with this disease will have a familial form. We think the genetics is very interesting. It's probably a spectrum, so that you need to have some genetic predisposition to get this disease. There are, it looks like, some mutations or some genetic variation that in many people will lead them to get the disease. So in the familial cases, they have a particularly a mutation that's particularly predisposing, so that many family members that have that mutation will get the disease. There are probably other people that have a mutation that's less causative or less likely to, can still cause it, and more so than the general population, but maybe one member in that family would be involved, although there is this genetic component. And then the other component are these exposures. And in some exposures, it's also a spectrum. So asbestos is a very exposure that very commonly causes pulmonary fibrosis. There are probably other exposures that, again, cause it in some people but not others. So we have this spectrum where sometimes it's mostly genetic, sometimes it's mostly exposure, but probably the vast majority of cases it's somewhere in between. There's some genetic predisposition and they are exposed to something, meaning they inhale something, that causes damage to the lungs, that in those particular people causes lung fibrosis.
A couple of slight tangents here. Now, we had mentioned that there isn't a lot of research that has been done. It's difficult to diagnose. It's difficult to treat. You know, the treatment's not known. How old or how long has this disease been around? At least from, you know, first known diagnosis.
So it's a really good question. I actually didn't know the answer to that until you emailed this, thinking that that might be something that would be interesting. So it looks like the first case described in the medical literature is from 1868.
Really? So it does go back that far? Okay.
Yeah. Now, probably was present long before that.
Okay.
It does, again, tend to be a disease of older people. So as the population is aging, it's probably becoming more common. Unfortunately, it looks like even accounting for that, it is becoming more common. And whether that's...
Well, now we just know what to look for.
Yes, I think there's... Oh, no, I think there's many factors. One, the diagnosis is easier to make, or easier for physicians to make. But probably, maybe there are worse exposures, environmental exposures that are worse now than they were before.
But we do have a phone call.
Oh.
And I don't know whose colleague it is, but Dr. David Lederer. Did I pronounce his name correctly?
Yes, hi. Thank you.
Hi. Thank you for calling. And you are with the Pulmonary Fibrosis Foundation, correct?
That's correct. I work with the foundation as a senior medical director for patient communications.
Okay. Now, have you worked with Dr. Tighe in the past?
Dr. Tighe and I have not worked together, but I know of his work because he's done some really outstanding work in mouse models of pulmonary fibrosis.
Thank you.
So we haven't really gotten too much into what the disease entails, but what does the foundation do? Does it support research? Does it support cures, medicines? I'm not even sure what to ask.
Sure. Well, that's actually a really great question, and I'm happy to talk about that. So the Pulmonary Fibrosis Foundation has two major missions. One revolves around advancing work towards new treatments and eventually a cure for pulmonary fibrosis. And so that means helping to support research that Dr. Tighe does and other scientists and physicians perform around the country. In addition, the Pulmonary Fibrosis Foundation also works very hard towards raising awareness about pulmonary fibrosis. I would not be surprised to find out that many of your viewers may not have ever heard of pulmonary fibrosis, or maybe they think it's cystic fibrosis, which is a different lung disease. And so we're working hard to try to raise awareness.
Okay, and what are some of the examples or ways that you try to raise this awareness?
So we try to do this in many different ways. Some of it is trying to educate healthcare providers, because you'd be surprised how many healthcare providers even don't know too much about pulmonary fibrosis, kind of scratch their head when they hear about it. And so we hold webinars, which we've begun to do this year. We go out and engage in speaking engagements, try to raise awareness among providers. We've also tried to raise awareness among the general public. This is obviously a bigger challenge. We do this through online campaigns, social media, and fundraising events.
Okay, great. I just had another question and it flew out of my mind. Do you guys have any questions quickly? Now, do you work with, actually, I'll just go to my cheat sheet. Are you aware of any of the tests that are used to define or to diagnose pulmonary fibrosis?
Oh, sure. So I'm a pulmonologist, and my area of expertise
I suppose I should have asked you that first.
Yeah, that's okay. So my areas of expertise are pulmonary fibrosis and lung transplantation, which is one of the major treatments for pulmonary fibrosis.
Okay.
And so, yeah, we've actually been working hard on trying to figure out how to streamline the evaluation of patients with suspected pulmonary fibrosis. I'll tell you that the initial test is that a physician or other healthcare provider needs to really listen carefully at the lungs. And this is something we're trying to get the word out about how important it is that doctors, nurses, nurse practitioners, and other allied health professionals listen carefully to the bottom of the lungs, where we hear a certain very particular sound called a crackle. That's a very distinctive sound that we hear in pulmonary fibrosis. We can also hear in other diseases. Okay. But we don't hear that sound in many common lung diseases like COPD, which stands for chronic obstructive pulmonary disease. Emphysema is a kind of COPD. We don't hear that sound in asthma. And many of our patients who are eventually diagnosed with pulmonary fibrosis may be told initially that they have asthma or they have COPD or some other medical condition. So the first test, so to speak, is a good, careful physical exam. And after that, the second most important test is getting a good, high-quality, what's called a high-resolution CAT scan of the chest, or a CT scan of the chest. And that can help us identify the presence of scarring. Fibrosis means scarring. And it also can tell doctors about the pattern of involvement of the lungs, if it's the top of the lungs, the bottom of the lungs, the outside of the lungs, the inside of the lungs.
Wow. That
can tell us a lot of information about what kind of pulmonary fibrosis it might be.
Okay. Now, are these tests and diagnoses generally, is it something that a primary care physician could provide, or does the patient need to be referred to a specialist like yourself in order to have these tests run?
Right. Well, initially, certainly, the first line is always the primary care provider. Having an index of suspicion that there might be something wrong with the lungs. My patient is short of breath.
Okay.
There are some crackly sounds in the lungs. And then, yes, going on to order a high-resolution CAT scan of the chest, going on to order other basic lung tests like spirometry, which is a type of pulmonary function test. Once that happens, though, then the next step would be referral to a pulmonologist and sometimes directly to a pulmonary fibrosis specialist in order for us to help not only identify the presence of pulmonary fibrosis, but have us help figure out which kind of pulmonary fibrosis it is. And it's estimated, I have never sat down to tabulate this, but it's estimated that there are over 200 different kinds of pulmonary fibrosis.
Wow.
Yeah.
Okay, I'd lose count, but okay. Now, you had also mentioned, if I understood you correctly, that sometimes the initial diagnosis might look like COPD or emphysema or, asthma. Does idiopathic pulmonary fibrosis often accompany these other diseases or diagnoses, or is it usually freestanding and just a mistaken identity of?
Yeah, well, I guess it happens both ways. I'd first say that there's lots of people who have asthma or have COPD who don't have pulmonary fibrosis. So I don't want any of your viewers to think that, oh boy, my doctor said I have asthma, now I got to make sure I don't have pulmonary fibrosis.
Understood. Didn't mean to send anyone into a panic.
On the other hand, many people who do have pulmonary fibrosis can also have other lung problems. They can have COPD at the same time. And we see people who have scarring in the bottom of the lungs, and they have emphysema in the top part of the lungs. And that's a very important condition that doctors need to look for when pulmonary fibrosis is present. There's another kind of lung condition called pulmonary hypertension. Many viewers may have heard of hypertension, which is simply high blood pressure. It's a medical term for high blood pressure. Pulmonary hypertension is high blood pressure in the blood vessels that connect the heart to the lungs. Those are blood vessels you can't wrap a blood pressure cuff around. They're inside of the chest.
Wow. Completely
different blood pressure. And sometimes that disease, pulmonary hypertension, can accompany pulmonary fibrosis as well.
Okay. I just had another question that flew out of my head again. Oh, I needed more caffeine before coming here.
I would pick up on one thing that Dr. Lederer said is
I thought of it.
That cigarette smoking is classically thought of as a risk factor for emphysema and chronic bronchitis, which are the two forms of COPD. But it's also, we think, a common risk factor for idiopathic pulmonary fibrosis. Why some people who smoked will develop IPF versus others will develop COPD, we really don't know. And that's actually a very an area of great interest to research. But the reason I bring it up is, again, since both diseases have this common risk factor, they can both occur in the same person, not uncommonly, as Dr. Lederer was saying.
I did remember my question. Now, Dr. Lederer, you're still there?
I am.
Okay. Did you also mention that you play a role in lung transplants?
Yeah, I'm a pulmonologist. I take care of patients who have pulmonary fibrosis. I also take care of patients who need a transplant, many of whom have pulmonary fibrosis, and I take care of them after their lung transplant. Okay,
because I was about to ask what what stage or how common is a transplant to pulmonary fibrosis patients, and where is that going?
Sure. So in the United States, there's estimated to be well over 100,000 people living with pulmonary fibrosis today. And while there are some treatments for some forms of pulmonary fibrosis, as you may have discussed earlier, there really are no proven available therapies in the United States right now for pulmonary fibrosis. And that means that as the disease progresses, and it does progress for many people, lung transplantation can be a life-saving option. Now, of those over 100,000 people living today with pulmonary fibrosis in the United States, in the next 12 months, only about 900 to 1,000 of them are going to get a lung transplant. It turns out that there's only about 2,000 lung transplants performed each year in the United States. And while pulmonary fibrosis is now the #1 reason for people in the U.S. to get a lung transplant, there are lots of other people who need lung transplants. People with cystic fibrosis, some people with emphysema or COPD, and a variety of other lung diseases. So there's a huge donor shortage. If we had many more lungs, we could save many more lives.
That was going to be my next question. We actually had a show earlier on organ donation. Not that you can, give up your lungs, but so can you I'm sorry, with the treatments, there are no successful treatments, or there are no known treatments, or can we go back and cover that a little bit more?
Sure. Well, maybe I'll start, and I'll let Dr. Tighe finish that, because he may have some really exciting stuff to share. So right now, in the United States, there are no FDA-approved therapies for pulmonary fibrosis. That's not to say there's nothing we can do for patients with pulmonary fibrosis, because there's a lot of good things that lung doctors can do for patients, such as maximizing their use of oxygen, which is a wonderful treatment that helps relieve shortness of breath, enrollment in exercise programs, and sometimes avoiding some of the harmful therapies that may be out there that people are trying. There are, however, two new drugs that seem to work by slowing down the progression of the disease in idiopathic pulmonary fibrosis, which is just one of those 200 different kinds of pulmonary fibrosis. Those drugs are being reviewed by the FDA, and we hope to hear something later this year, maybe early next year. And I'll defer to Dr. Tighe to talk maybe about some of the drugs that are undergoing clinical trials right now, which are really exciting.
So yeah, it's gotten to be quite an exciting time, or a time of, I think, optimism for being able to change the outlook for patients with pulmonary fibrosis, other than those that can be taken care of by lung transplantation. And I think that a lot of this can be traced back to better understanding of what's going wrong in the lung in patients that are developing pulmonary fibrosis. And about 15 years ago or so, there was a sort of a paradigm shift in what we think is happening in pulmonary fibrosis in terms of what's really driving this disease.
Okay.
And we had previously thought that this was a disease of chronic inflammation, the way asthma is a disease of chronic inflammation. Perhaps patients are allergic to something. To really thinking that this is a disease of something that is over and over injuring the lung. And in some ways, it's almost analogous to what happens in cirrhosis of the liver, which is fibrosis of the liver, which is chronic damage over time, in that case, from alcohol.
Okay.
In IPF, again, as we talked about before, we're not sure in most cases what's injuring the lung, but we think what is happening is repetitively, the lung is being injured, and then rather than repairing itself normally, it's scarring. And so again, as Dr. Lederer mentioned and we talked about before, fibrosis is essentially just scarring of the organ, where it loses its normal structure and then loses its normal function, and which in the lungs is to get oxygen from the air into the bloodstream. So once that became clearer, people were able to start looking at what is going wrong in the IPF lung. Why is the lung not repairing itself? Why is it developing all this scar tissue? And that led to the identification of certain molecules that there may be too much of or not enough of others in the lungs that scar as opposed to the lungs that heal.
Now, sorry to interrupt, but you mentioned singular lung. In most cases, or does it usually happen in one lung or two lungs?
No, it's usually both lungs together. It's interesting in that the disease tends to be patchy, although it does have a predilection for the bottoms of the lung and the outsides of the lung. But by and large, it does affect both, although not uniformly. But this led to an identification of new molecules to what we call target. In other words, for people to make drugs that inhibit or augment these new things that are involved, we think, in the causing of the disease. And this has led to a number of new agents undergoing clinical trials where when we don't know if a drug works, they're first given randomly to some patients, and then the other patients get what we call a placebo, or something that we don't think has any function. And then we compare how the patients do, given one treatment or the other. And as Dr. Lederer just mentioned, there have been two recently finished trials of two different drugs, both of which showed that the patients that got treated with those drugs, the progression of their fibrosis was decreased. It slowed the loss of their lung function. And that, again, is there have been a lot of trials that have all been negative. Some trials that have actually showed drugs that we thought might be helpful were actually harmful. And which is, again, why...
Don't think I want to be in that study.
No, exactly why it's so important to subject all these new therapies to rigorous clinical testing involving this kind of comparison to placebo. But these two drugs, one called pirfenidone and one called nintedanib, both showed success in slowing progression of disease, which for us and for the patients is, again, hasn't been seen before. As Dr. Lederer mentioned, they're not yet approved for use in the United States. That then goes to the Food and Drug Administration that needs to review the data and decide that, yes, this is safe.
Where are these tests being performed if they're not available in the U.S.?
So the way that
trials taking place in the U.S., but they haven't been
exactly right. So the trials
for
both of these, the recent trials were multinational. There were a lot of centers in the U.S., but also centers in other countries. And then all the data was compiled. So Our hospital, I'm sure Dr. Lederer's hospital took part in some of or all of these trials, and patients with the diagnosis of IPF would come in, and those trials we'd say, well, we don't have any established therapies outside of if you're a candidate for transplant that we know can help, but would you be interested in participating in this clinical trial of a drug that we think may help and that we hope will help, but that we don't know yet whether it'll help. And unfortunately, in some cases, trials have to be stopped. They're monitored, even though the physicians taking part of them don't know which patient is getting what disease. There are people that are aware of that, and over time will look at how people are doing, and if it looks like the drug is causing harm, then the trial will be stopped early. Because again, the paramount concern is the safety of the patient. But with that, many of these trials in IPF had been conducted that showed no benefit, but these 2 trials did show a benefit.
How long does a trial normally last, and how many trials do you have to go through before seeking FDA approval?
So the trial length can vary. Most of the recent trials in IPF have been putting subjects that enrolled in the trial on 1 year of therapy, 52 weeks of therapy. And there are some trials now going that are going longer. There are other trials that have tried to go shorter. I think it's a strategy of these trials are very expensive to run, and the longer the trial runs, perhaps the better chance it has of showing an effect, but the more expensive it is. So that's a balance that the sponsors need to make. But it all needs to be pre-specified. So you have to make your best, take your best shot, so to speak, because if it's 52 weeks and it's not positive, but it looks like there was a trend, you can't really go back and say, I really want it to be 2 years. But then the Food and Drug Administration in the United States, in these cases, have been wanting to see 2 independent trials be positive before they'll give approval. And one of these drugs, pirfenidone, actually had 2 large trials previously, and one was positive and one was not. And there was also a Japanese trial that was positive, and based on that, the drug was approved in Japan, in European Union countries, in Canada, in Argentina, but not in the United States. The FDA decided not to approve. And so now that company has run a 3rd trial, which was positive, and now it's again being re-reviewed at the FDA. The other drug, nintedanib, also ran 2 trials, and they were both positive. So that is also now awaiting assessment by the FDA.
Now, are these drugs or medications, is it like an oral thing, or is it more like a chemo, like injection or radiation, or how is it administered?
These are both oral pills. So there are some drugs being tested now that would be a weekly or every other week injection. But these 2 that looked positive so far are both pills.
Because I'm just thinking from the patient's perspective, if it has to be like a radiation treatment type thing, having to go, it's just more of an inconvenience. Not that you wouldn't not want to take the medicine, but now one of the medicines, one of the trials you've mentioned have slowed the progress down. Now, is your, I don't want to say immediate goal, but within the next 2 to 5 years or something, finding a treatment that can stop the progression, and then like maybe 5 to 10 years after that, reverse? Is that a possibility in
We think so, we hope so.
Or is that one of your
and
goals?
I think so, yes. A lot of things that we're doing now, or treatments that we're designing now, would be designed mostly to stop the progression of the fibrosis.
Okay.
As opposed to things that might actually reverse already existing fibrosis.
Okay.
Now, what we may find is that the liver is a good example of an organ that has a significant capacity to regenerate or repair itself.
Okay.
And that in the liver, a lot of times if you can stop the fibrosis, one of the most common causes of liver fibrosis worldwide, besides alcohol, has been hepatitis C virus.
Okay.
And that if you can treat the hepatitis C virus, the liver can recover from the fibrosis that the virus caused. Not in all cases, it may cross a certain threshold, but there's a lot of regenerative capacity. We've generally thought that's not going to be the case for the lung.
Okay.
But I think the lung may be able to regenerate a lot better than we give it credit for. There are cases of patients having a different disease where they get terrible fibrosis in something called adult respiratory distress syndrome.
Okay.
But then if they recover from that, survive that and recover, if we see them back a year later, they've regained a lot of lung function. So the lung may be actually able to regenerate. So stopping progression may do more than we think it will.
Cool.
Not to say that that
no,
isn't,
I understand.
You know,
I'm
that
not
isn't
going to.
a great intermediate
I'm making
goal.
notes, but
Yes.
that's not because I'm trying to quote you for later. Honest. Now, Dr. Lederer, are you still there?
I am.
Oh, yay. Okay, I have another question that I'm not sure which medical professional will be able to better answer this. Now, we had talked about some patients being available or prioritized for a transplant. Is there such a thing as a partial lung transplant? Like if it's just like the bottom of the lung? Okay, I did not go to medical school. I didn't even take, biology too. But like reducing the size of the lung to cut out the bad scarred tissue and still have a patient live a relatively normal life. Is that a possibility?
It's a common question. It's a good question. And it kind of makes sense, right? You'd say, well, if you have the scar tissue in one part of the lung, and I think Dr. Tighe referred to that very common pattern where it's really just in the bottom of the lungs,
if you catch
you just cut that out and then it's not a problem. Well, what happens is if you were to do that, you'd leave a person with smaller lungs that weren't working that well. So you'd probably end up harming them rather than helping them. And then the related question is, could you just replace half a lung? Could you do half a lung transplant? And anatomically and for practical reasons, that doesn't necessarily work as well as replacing an entire lung.
Okay.
I will say that most people who have pulmonary fibrosis who go in for a lung transplant, most can get away with having just one of their lungs replaced, the left one or the right one, rather than having both replaced.
Okay.
And when we do a single lung transplant, again, most of the time it works just as well as a double lung transplant. Okay,
so I mean that kind of not really helps, but seems to increase your chances of, treatments available, maybe from the uneducated, non-medical perspective.
Sure.
And the other question that I had was, earlier I had asked about if someone is being diagnosed or has idiopathic pulmonary fibrosis, that it might disguise itself as another disease at first. Now, the question that I have now is, if someone has idiopathic pulmonary fibrosis, are they at risk of coming down with other ailments like bronchitis, or are they more susceptible to pneumonia or you know, lung cancer, or does it increase the chances of getting something else? I guess is my question.
Yeah, that's also a very good question. The bottom line is that people who have pulmonary fibrosis, particularly when the disease has reached an advanced stage, are very prone to sudden worsenings of the condition. Sometimes those sudden worsenings are infectious in nature. So that would be a severe bronchitis or a pneumonia. In other cases, people with advanced pulmonary fibrosis can develop a sudden worsening, which we call an acute exacerbation, that doesn't seem to be related to an infection, and it occurs for reasons we don't really understand. And sometimes that sudden worsening can be quite serious and even life-threatening.
Okay. Wow. I'm just coming up with all these other questions, and my mind's just getting blown. Okay. Let's jump over to kind of changing the pathway a little bit. In Ashley's case, your grandfather was diagnosed. Are there support systems or opportunities for you to get support, either for you as a family member or someone actually diagnosed with the disease, to kind of help them through this? Or is that what the foundation's for?
I think that's precisely what the foundation is for. And I think, you know, through our brief work of 3 years, certainly the Pulmonary Fibrosis Foundation has far more history than we do. We're also kind of trying to do that at a more local level. So through our walk, and we also do a Zumba event at Miss Louise's in Burlington. So
love Miss Louise.
Yes, she's great. And the Zumba is certainly very fun as well. So through that, we're, you know, building a local community, and the walk itself, you know, despite being named for my grandfather, the John F. Tighe Walk for Pulmonary Fibrosis, you know, there are other families that do come and they honor their loved ones prior to the kickoff of the walk, which is, you know, has been, I think, great for everyone.
Okay. Are there national, with the Pulmonary Fibrosis Foundation, are there national support systems?
Yeah, I can answer that. So there are. So we at the foundation have found that people with pulmonary fibrosis and their families, as they're being diagnosed, they really need two things. One is information, and we do a pretty good job of getting that information out when people reach out to us. And the other is support, and the foundation's been working for a long time to build up a support group network across the country. I don't have the latest numbers off the top of my head, but we now have dozens of individual support groups around the country that are often run by patients with pulmonary fibrosis or caregivers of people with pulmonary fibrosis, sometimes run by medical professionals. It's all organized through the Pulmonary Fibrosis Foundation, which provides a little bit of support and infrastructure for the support group leaders. And it continues to grow. I think, again, I don't have the number off the top of my head, but I think that this year we launched 14 additional support groups on top of the existing ones we have, and there are more and more popping up each and every month.
Okay. Where is your foundation based?
The Pulmonary Fibrosis Foundation is based in Chicago, Illinois.
Oh, okay. So you're calling from Chicago right now, right?
No, I'm actually calling from New York. I work at Columbia University Medical Center in New York, and I spend about a quarter of my time working with the foundation.
Okay. See, I asked your two guests here, I interrogated their background, and I kind of forgot to ask you yours. So I apologize.
Oh, that's okay.
First time that I've had a guest from a different area code.
And I also think in addition to the support for the patients and for their families, things like that Ashley and her family have done, I mean, really do an enormous amount, I think, to help us in our efforts to find new cures and so forth. I think there's, even right now, it hasn't been a great time for federally funded initiatives, just in terms of budget deficits and so forth, and the National Institutes of Health, which funds has traditionally funded the lion's share of medical investigation in this country. Its budgets are being constrained, similar to other things. Even before maybe that, the downturn, and even before the financial downturn, even before the NIH budgets became so constrained, there's a predilection for those agencies to really try and fund things that they again think by investigators' track records would be most likely to succeed. So there tends to be a slight conservative nature. When I was a young investigator and just starting without much of a track record and a new area of research to explore, it was difficult to get funding from the National Institutes of Health. And I was funded directly by Ashley's family and through the Pulmonary Fibrosis Foundation, and that work led to identifying a new molecule that hadn't been implicated in pulmonary fibrosis before, and now there's a drug that's in clinical trial to target that molecule. And so I think the philanthropy that families do and that the Fibrosis Foundation does, they have a terrific grant program, is really pivotal even before federal resources were so constrained. But now in the current situation, it really can make the difference between young investigators being able to continue to do scientific research and try and find new cures, or really have to give up and not do that at all. So I think it really can't underestimate, or you really can't overstate, that's what I mean, can't overstate how important the activities are, so that that families like Ashley's family really are giving back in a really meaningful way in terms of the fundraising activities and the foundation's activities, in addition to the awareness and support group, which is also incredibly helpful for the patients today.
Okay. Well, I'm also thinking, back to earlier in our discussion where we had mentioned that not a lot is known either from the scientific community or just the community in general. There's not much known about idiopathic pulmonary fibrosis. So trying to fight for some of that government support, it's the little hand waving. You need a bigger hand, you need the big poster and everything to kind of get yourself noticed. The squeaky wheel gets the grease type thing. Now, we only have a few minutes left, so I do want to turn the focus back to Ashley.
Great.
Dr. Lederer, you're more than welcome to stay, but we're just going to kind of wrap things up now. So,
all right. Well, thank you for having me.
I really appreciate your calling in. Sure. Thanks so much. Okay.
Yes.
You have the big walk
We
coming
do.
up.
Yep, September 20th.
Tell me about it.
Sure. So, actually, we started it the year after my grandfather passed away. It's just a means to, again, raise awareness and funding for Dr. Tighe and the Pulmonary Fibrosis Foundation. So this is our 4th year.
Okay, it's September
20th.
20th.
Which is a Saturday.
Okay. Now, how does registration happen?
Sure. You can find a link to the registration on Battle for Breath's website, which is www.battleforbreath.com.
Okay.
So all the information that you need to know is on there. Yep.
Is it like a team thing, individual thing? Because
you can do both.
Okay.
Yep. So we have individual registration, but certainly we've had families register in the past as well.
Okay. Because I'm thinking of like the Relay for Life. They have the big team building thing. Now, is there a minimum that is it just a registration fee that they have to pay, or do they have to raise X number of dollars based on?
It's a simple registration fee, and certainly we encourage further donations. That always helps.
But it's a reasonable, okay.
Yes.
And how long is the walk?
Sure. It's actually at Horn Pond. So we do a lap around the pond, and some folks keep going, and others stay for refreshments and goodies.
Okay, so what time is the walk at?
Registration starts at 1, and the walk starts at 2.
Okay, and how many people do you expect this year, or based on how many people you've been
so
getting?
we've seen a good amount of growth over the course of 3 years.
Excellent.
Our first year, we probably had 20 to 25. The second year, I want to say closer to 50, and last year, I believe we had about 80. So steadily growing.
Easily break the 100
That's
mark.
what we're shooting for.
That's great.
Yes.
That's really great.
Now, is it family friendly or?
Absolutely. Yep. I brought my 2 dogs last time, so dog friendly as well.
Dog friendly as well.
Yep. Definitely
On
families
leashes?
registered. Yes. Absolutely.
No swimming in Horn Pond.
No. But certainly there are families that come with their little children with, you know, baby carriages and all that. So absolutely family friendly.
Horn Pond's a pretty flat,
It
easy
is.
walk.
Yep. Yep. Absolutely.
Okay. Now, what gave you guys the idea to do a walk?
Yeah, that's a great question. I mean, I think we got
That I didn't
inspiration.
rehearse.
Come on. No, I think we got the inspiration from other organizations around us, right? It's a somewhat common thing to have a walk, a fundraising walk. So that was kind of our inspiration. We took the great idea from others.
Excellent. And off the top of your head, don't mean to put you on
No,
the spot,
absolutely.
but I will. Now, you had mentioned your volume or your people goal
Yes.
is roughly 100. How much money do you hope to raise? Does the foundation have a goal in mind?
You know, so over the past 4 years, I believe we've raised close to 80,000.
Excellent.
Combined. Ideally, you know, certainly we'd like to continue to build on that.
Right.
We don't have a specific goal in mind, but just encourage people to donate and help us build that pool.
Okay. Now, the monies that you raise, does that go to the National
It goes to the Pulmonary Fibrosis
Foundation?
Correct. And then it gets dispersed in the form of grants.
Okay. Which Dr. Tighe is then eligible
Exactly.
for?
Yes.
Okay. Now, is that how you guys kind of got hooked up?
It is, yes. So when we first wanted to get involved in, you know, building awareness and raising funds, we reached out to the Pulmonary Fibrosis Foundation, who then put us in touch with Dr. Tighe,
Okay.
which was about 3 years ago now, 3 or 4.
Okay, so it was after your grandfather had passed?
It was, yes.
Okay. I wasn't sure if, you know, you played a role in his treatment or, well, there isn't really a treatment, but okay.
Yes, it was after the fact.
Okay, excellent. Now, are you going to be participating in the walk? No pressure. No pressure.
Sure, put you
No
on the
pressure.
spot.
I unfortunately will be at a pulmonary fibrosis conference in Canada that date, but
So
I've
it's
been
like a really
donating every year.
So it's like a really
Fantastic.
international issue, isn't it? Wow. Now, do you work internationally with?
Yeah, we have collaborators in Mexico. We have collaborators in Canada, in the UK, in Germany. So it is really quite an international effort. Japan as well. We have collaborated with people.
Excellent.
So yeah, it's really a disease that really seems to be widespread worldwide. And the other thing is, I think that again, the progress that we're going to make on idiopathic pulmonary fibrosis is going to spill over to other diseases. It's been estimated that an enormous amount of disease in all organs has some component of scarring. Common diseases like atherosclerosis, coronary artery disease, there's scarring of the blood vessels, and that we don't have good treatments for any of these scarring diseases. I think pulmonary fibrosis has been one of the fibrotic diseases where the research has gotten the most support and made some of the best progress, and I think that's going to be great for our own patients, but I think also it's going to have a lot of great spillover effects. So I think that's really going to multiply efforts of Ashley's family and other people that are being so generous with their time and
Speaking of
funds.
time, we are out of time. So thank you, Dr. Tighe. Thank you, Dr. Federer. And thank you, Ashley,
Thank you for having us.
spending the past hour talking. Best of luck to you in your research.
Thank you very much, and thank you for having me on.
Best of luck in the walk.
Thank you.
And maybe I might sign up for some.
Oh, come on.
Well, I have my Irish step dancing class right before it, so
no.
usually by the time Zumba shows up, I'm ready to crash. So I do want to thank everyone at home for tuning in this evening and watching, and hopefully you were able to learn something new. I know I definitely was. Enjoy your summer, enjoy this wonderful weather, and see you around town. Thanks. Good night.